Hi guys, this is my poster presentation based on the NSQHS Standard 5, Comprehensive Care, and it's going to be specifically focusing on the prevention and management of pressure injuries. The fifth standard aims to ensure that patients receive care that meets their individual needs and is clinically appropriate, is aligned with the patient's expressed goals and healthcare needs, considers the impact of their health issues, life and well-being, and the risk of harm is prevented and managed by implementing targeted strategies. So as you know, pressure injuries are a localized injury to the skin and/or underlying tissue as a result from pressure over a bony prominence, shearing forces, and friction. They affect the quality of life of the patient, their ability to function. They leave them at a greater risk of infection, are painful, and increase both the cost and length of their stay in hospital. However, as you all already know, pressure injuries are preventable. Through early recognition, assessments, interventions, and ongoing evaluation, we are able to both prevent and manage pressure injuries. For the prevention and management of pressure injuries, the standards guidelines require health organisations to 1. Conduct a screening, 2. Conduct risk and skin assessments, 3. Implement prevention plans, 4. Assess existing pressure injuries, 5. Treat existing pressure injuries, and 6. Monitor and document. So part 1. Clinical assessment and diagnosis. On admission, the admitting nurse must complete a thorough head-to-toe examination of the skin, identifying and grading any pre-existing pressure injuries and contributing risk factors the patient may have. The same assessment should be repeated daily or each shift as per the assessed level of risk of the patient. The skin assessment should include the skin's integrity, temperature, colour, moisture and skin turgor, areas of pain or discomfort, and pressure damage relating to devices. If a pressure injury is present, you must assess and document location, size and depth of the pressure injury, appearance of the wound bed, odour and amount of and type of exudate, the level of pain and discomfort caused, and the condition of the wound edges and surrounding skin. Classification and grading of pressure injuries are as follows. Stage 1, non-blanchable erythema. Stage 2, partial thickness and skin loss. Stage 3, full thickness and skin loss. Stage 4, full thickness and tissue loss. Unstageable, depth unknown, and suspected deep tissue injury with the depth also unknown. Very common locations for pressure injuries include the back of the head, shoulder, elbow, buttocks, heels, ears, hips, thighs, rib cage, knees and toes. Section 2. Risk screening and assessment. Risk factors for pressure injuries can be separated into two broad categories: pressure-related and tissue tolerance, with extrinsic and intrinsic factors. A comprehensive assessment should be made within 8 hours of a patient's admission to recognise risk factors and identify appropriate interventions, and this should be repeated as their condition changes. The use of a validated pressure injury risk assessment tool, such as the Braden scale, can help determine the degree of risk a patient has for developing a pressure injury. Pressure-related risk factors. A patient with impaired mobility, activity or sensory perception is unable to shift their weight and respond to pressure-related discomfort, leaving them at greater risk of a pressure-related injury. This may be caused by neurological conditions, a spinal cord injury, cognitive impairment, trauma, surgery, obesity, diabetes, and medications such as sedatives. Tissue tolerance risk factors. The skin's ability to heal from and tolerate pressure is affected by friction and shear, moisture and incontinence, poor nutrition and hydration, chronic illnesses such as diabetes or lymphedema, diseases that affect oxygen delivery, and the effects of aging, so decreased vascularity, sensation, and lymphatic function. When completing a comprehensive skin assessment, you should include the patient's clinical history, their pressure injury risk, their mobility assessment, nutrition, cognition, continence, and extrinsic factors affecting the patient, such as moisture, shear, and friction. The use of a validated pressure injury risk assessment tool, such as the Braden scale, helps assess the level of risk a patient is of developing a pressure injury. The Braden Risk Assessment Tool is a scale made up of 6 subsections, where each item is scored between 1 and 3 or 1 and 4. These subcategories are sensory perception, moisture, activity, mobility, friction, and shear. The Braden scorings are as follow. So a patient is at mild risk if they score between 15 and 18, moderate risk if they score 13 to 14, high risk if they score 10 to 12, and very high risk if they score 9 or less. So looking at the subcategories, in sensory perception, a patient will score 1 if they're completely limited, so they're unresponsive or have limited ability to feel pain. 2, very limited sensory perception, where they respond only to painful stimuli or has a sensory impairment. 3 is slightly limited sensory perception, so they can respond to verbal commands but cannot always communicate their discomfort. Or 4, they have absolutely no sensory perception impairment. So in moisture, so a patient scores 1 if they are constantly moist, so this could be perspiration, urine, drainage, any kind of dampness noticed when the patient's moved, whenever they're moved. They'll score 2 if they're considered moist, so the linen requires changing at least once every 8 hours. 3, they're occasionally moist, requires linen changing at least once a day. Or 4, rarely moist, so they're continent, they're not perspirating too much and just not damp at all. So in their level of activity, so a patient will score 1 if they're bedfast, so they cannot get out of bed, they cannot sit. 2, when they're chair fast, so they're non-weight bearing or require transfer assistance of any kind. They'll score 3 if they can walk occasionally, however spend the majority of their day in the bed or a chair, so they don't get up and adjust much. Or 4, when they can walk often and freely and as much as they want. So in mobility, the patient will score 1 if they're completely immobile, so they cannot make any movements without assistance. 2, they're very limited, so they can make slight movements, but they're not very frequent and they're not very large, so just only slight ones. They'll score 3 if they're slightly limited, so they can make frequent slight movements independently. And they'll score 4 if they have absolutely no limitations, so they're independent. So in nutrition, a patient will score 1 when their nutrition is considered very poor, so they're maintained on IV fluids, or they rarely eat more than 1/3 of a meal a day. They'll score 2 if they're probably inadequate nutrition intake, so they're on a liquid diet, they rarely eat more than half of a meal a day, and they occasionally take supplements. They'll score 3 if they have adequate nutrition, so this could be tube feedings, or if they eat over half of most of their meals and they don't require any supplements. Or 4 if they eat excellently, so they eat most of every meal and they're on a normal diet. And then the final subsection, which is friction and shear, so a patient will score 1 if friction and shear is a problem and they require maximum assistance on bed for bed mobility and frequent repositioning, and so there's just constant friction. 2, so friction and shear is a potential problem, so they require min assist, but they can slide on surfaces, so to some extent. And they'll score a 3 if there's no apparent problem of friction and shear. Section 3, Interventions and Implementing a Comprehensive Care Plan. So I'm going to discuss 4 types of interventions. Number 1, repositioning. Patients who are unable to recognise or respond to pressure-related discomfort require frequent assistance with repositioning. A patient who is bedfast and completely immobile should be repositioned a minimum of every 2 hours. You should alternate the patient from laying on their left and right side at a 30-degree angle and on their back. To prevent friction and shear, if a bedfast patient is required to sit at an angle greater than 30 degrees, the patient needs to be supported from slipping down the bed with like a pillow or something. A chair-fast patient with very limited mobility should be encouraged to or assisted with repositioning every hour and to sit on a pressure-relieving cushion. In addition to repositioning of the patient, you should also think about repositioning devices, so AFOs, nasogastric tubes, catheter straps, and etc. Intervention 2, skin hygiene and continence management plan. Extended exposure to excessive moisture leaves the skin vulnerable and weak to pressure, friction, and shear. When a patient is incontinent, their skin is at an increased risk of damage and bacterial growth due to alterations in pH. The pH of urine is 5.5 to 6.5 and stool pH is 7.0 to 7.5. With the presence of ammonia, the pH of the skin can be raised from the normal pH of 5.5 to 5.9 to 11. By implementing a continence management plan and providing proper hygiene, you can help reduce the risk of pressure injuries and maintain skin health. Regular pad changes and/or commencing a toileting regime will help. Use a pH-neutral soap or cleansing product when attending to hygiene. Use a non-abrasive cloth also to prevent damage to the skin. Use of barrier creams, wipes and moisturizers are really good, and ensure the skin is dried properly. Intervention 3, the use of devices. An alternating air pressure mattress is a mattress that relieves the pressure over the bony prominences of a patient. It does so by inflating and deflating air-filled sacs over short periods of time to redistribute the patient's weight. Gel cushions. Gel cushions are made of dry gel polymers arranged in a series of columns that, when pressure is put on the cell walls, they gently collapse, allowing for greater distribution of weight across the surface area. Devices for offloading. So bed cradles, cushions, heel wedges, and pressure relieving boots are all devices that can be used for offloading, which is any measure used to relieve pressure over a bony prominence. And the final intervention, the use of dressings. So factors affecting dressing selections are the etiology of the wound, exudates, wound history, odour, comorbid conditions, the perimeter of the dress of the wound, the base, access to the wound, the size of it, and the patient or caregiver's needs. The dressing should also keep the tissue moist and the surrounding tissue dry, and if possible, use a bandage rather than tape to secure the dressing. Types of dressings include a film dressing for stage 1 pressure injuries. They allow for oxygen penetration and release of moisture, and are waterproof. For example, an OpSite. Foam dressings for stage 2 to 4 pressure injuries. They're highly absorbent yet maintain a moist wound surface for healing. An example of a foam dressing is a Biotane. Hydrocolloids for stage 2 pressure injuries. They're absorbent but maintain moist wound surface, and they're waterproof. An example of one is a Duoderm. Allignate dressings for stage 3 to 4 pressure injuries. They're seaweed-based, non-woven, absorbent dressings that form an absorbent gel when in contact with the wound. And other dressings include honey-impregnated dressings that have antimicrobial and anti-inflammatory properties. They promote rapid healing and improved healing. You can also have silver-impregnated dressings, which again have antimicrobial properties. And for my final section for you guys today is the documentation and management, and just basically how we're going on the ward. So in order for this poster to be most beneficial to us, I thought I would include some kind of assessment relating to our performance. So the following data was collected from the Integrated Risk Assessment and Care Plans that were filled out on the 17th of Jan this year. and they reflect where we're failing to document and or identify the risk factors, interventions, and appropriate assessments required for our patients. So for incorrectly documented risk factors, 8 out of 31 patients were incorrectly documented on being able to sense and respond to pressure-related discomfort. So this risk factor is not limited to device-related discomfort, as is often misinterpreted on the Integrated Risk Assessment and Care Plan. So a patient who has any sensory impairment or cannot communicate their discomfort is at risk of pressure injuries. And additionally, a patient who is unable to make frequent or large movements in either just a single limb or more is considered unable to sense and respond to pressure-related discomfort. 10 out of 31 patients were incorrectly documented to be at risk of friction and shear. Any patient who requires min-assist bed mobility or more, or slides to some extent against surfaces, is deemed at risk of pressure injuries due to friction or shear. By identifying this risk and by using slide sheets or lifting a patient's feet to prevent them from sliding down the bed, you can prevent friction and shear associated pressure injuries. Additionally, 9 out of 31 were incorrectly documented to have had a previous or current pressure injury. So this indicates that we're unsure if our patients have had or currently do have the pressure injuries. And it's important that we know this information and that we document it to ensure that continuity of care and that the correct preventative measures and interventions are in place for our patients. So incorrectly documented interventions. 9 out of 31 patients were incorrectly documented to be using pressure relieving devices. Despite the frequent use of these devices in our ward to assist in pressure injury prevention, we're not documenting that we're using them. We need to ensure that we do document our interventions correctly so that we can effectively evaluate the patient's pressure injury prevention plan and to ensure continuation of care. And then we've also got 6 out of 31 patients who were incorrectly identified to need repositioning. So again, any patient who is chair fast, bed fast, or unable to sense or respond to pressure-related discomfort require frequent positioning. It's important to record this and the intervention to ensure continuity of care. And lastly, we've got incorrect documented frequency of skin checks. 35% of the time, the documented required frequency of the skin check was incorrect. If a patient is moderate to very high risk of pressure injuries and or has a wound, a skin check should be performed at least once a shift. And that's it for me, guys. Thank you for listening.